session of the World Critical Lung Day. And during the next few minutes, we're going to speak about the new protocols for sedation in the era of COVID-19. My disclosures before thanking the organizers of this event and the invitation to participate and to Bell Pharma for this support and this participation. During these months, we have had to care for an elevated number of patients in mechanical ventilation that have required sedation and deep analgesia with limited resources. And we have found ourselves in situations of not enough pharmaceutical supply. And we have had to find strategies to reduce the days of mechanical ventilation in patients with a very prolonged hospital stay, not only because of drug problems, but the relation between the use of sedation and the post-ICU syndrome. That is why we need to assess and establish adequate sedation strategies, looking for innovation. And to talk about all of this, we're going to have three excellent talks with three international speakers.
Good afternoon. It's a great pleasure to be here. Thanks to organizer to invite me. And in the next 15 minutes, I will speak regarding winning in COVID patient. Here is a quite recent systematic review regarding the use of COVID-19. And as you can see here is reported the use of invasive mechanical ventilation in different studies, and mechanical ventilation can range between 7 up to 70% of the case. Regarding the outcome in intensive care, the percent of the patient. So why we have to apply mechanical ventilation admit in emergency department, in intensive care, in the hospital with COVID and presents severe respiratory failure, has a severe impairment of oxygenation. This is a typical patient, can be not dramatically because there is a little amount of ground glass and a minimum amount of consolidation. The same patient, after 7 days, presents a similar impairment of oxygenation. But look here, the CT scan is dramatically different. In the lower part of the lung, there is a huge amount of consolidation, while in the upper part is the ground glass consolidation. So what's happened to this patient? At admission, this is quantitative of lung, the blue part as a healthy, while the red, the first phenotypes, usually in the first days of mechanical ventilation, present a good compliance, so the severity of lung impairment is not so high. So we have to apply tidal volume between 7 and 8 ml per kilo. This does not translate to increase in the higher driving pressure. We have two phenotypes. First phenotypes in the early phase is characterized with good lung compliance. So we have to apply tidal volume between 7 and 8 ml per kilo. So this does not increase the driving pressure and could avoid resorption at atelectacy. And we have to apply low level of PEEP. Moving from first day after 6 H, this is characterized by low compliance. Then we have to win the patient. So to know the proper timing and rate of winning from the respirator, there is no a fixed rule. It is based on judgment and clinical experience. As a general rule, winning should be started as early as possible. So we have to balance by the respiratory load and the respiratory capacity. So the low is the lung disease, the cardiovascular dysfunction, and the chest wall. The capacity of the patient to sustain winning is based on possible muscle weakness, alteration in respiratory drive, and impairment in the neuromuscular function. So we have to approach. An aggressive approach minimize the duration of ventilatory support, and this can be associated to a risk of possible reintubation. A conservative approach minimizes the frequency of reintubation, but it is associated with risk of oversupport. This was an observational study coming from 15 Italian intensive care during the weaning phase. So more than 400 patients were studied. All patients were mechanical ventilation, and here patient who had the first column, second column patient who presented an unsuccessful weaning. The difference between the two groups is regarding impairment of oxygenation. So patients who present a good weaning present a higher oxygenation, and during the intensive care, the duration of mechanical ventilation was significantly lower compared to the tracheostomy. A lower amount of patients present a successful liberation from mechanical ventilation. A possible improvement, the weaning, could be to perform an early tracheostomy. This was an observational study, single center, performed in only 50 patients, and patients were divided according to the early compared to the late tracheostomy. Here are the baseline characteristics, and after 7 days, it was not associated with significant difference regarding the impairment of oxygenation. But look here, at 7 days of mechanical ventilation, patients who underwent early tracheostomy, so before 9 days, compared to late tracheostomy performed after 9 days, and the average was 13 days, present a lower amount of PEEP. And here is what's happened to the possible liberation from mechanical ventilation. So patients who underwent early tracheostomy had a lower amount of mechanical ventilation compared to late tracheostomy. So this is a possible clinical criteria that can be used in patients underwent invasive mechanical ventilation with COVID-19. So at bedside, chest X-ray is very important to have an idea regarding the amount of the disease and the spread. Patient could present an adequate oxygenation, PO2-FO2 ratio higher than 200 with lower amount of PEEP. Patient should present a stable cardiovascular system, adequate cuff, so adequate muscle, adequate ventilation, so not hypocapnia, neither hypercapnia, and not fever, and a good level of Glasgow Coma Scale. What we have to look by ultrasound, we have to look the diaphragm excursion and also the thickness fraction during inspiration. Here are the index of diaphragmatic function during the weaning from mechanical support. If diaphragmatic excursion during spontaneous freeze, the possible failure of spontaneous breathing. We have also to look the thickness. The thickness should be higher than 35%. And also we have to look the excursion in the right and in the left side of the diaphragm. With the ultrasound, we also look the presence of B-line and consolidation. And also we can have an idea regarding this score regarding the amount of B-line from 0, so lung without B-line, 0.1, the presence of moderate loss of aeration, 0.2, a severe loss of aeration, and 3 point, a complete loss of possible increase of weaning. On the contrary, higher than 17 increase the failure of extubation. With ultrasound, also we have to quantify the possible presence of pleural effusion. If patient present a small amount of pleural effusion, this does not affect the weaning. On the contrary, the presence of large pleural effusion increase the possible failure of the weaning. How we can conduct the weaning? This was the most recent chest ATS recommendation, patient without COVID. But my opinion that this recommendation can also be used in patient with COVID. So for patient ventilated for more than 24 hours, it has been recommended that initial spontaneous breathing trial during the time rather than TPIs or CPAP. And also this is very important. We have in our intensive care protocol to minimize the level of sedation. So my conclusion is we have to start as soon as possible the weaning. The tracheostomy can be useful in patients with acute respiratory failure with COVID-19. Ultrasound is very useful to evaluate the activity of the time of excursion, thickness, type of the weaning strategy. My suggestion is to use pressure support so we can treat step by step the reduction in the level of assistance. Thank you very much.
About sedation techniques, but actually I would like to expand a little bit my topic to technologies, because in fact we need technique, but we also need a guide and some support for delivering sedation in intensive care. I have conflicts in the sense that I have provided consultancy for Ever Pharma, and I invite you to maybe take a screenshot of these slides, because I think there's lots of controversial issues I will not be able to cover with this presentation. I think 15 minutes have been told. So please connect, and maybe we can have a conversation after this meeting, some more questions after this meeting. So at the beginning of this pandemic, large interest was given to the need of ventilators. Politicians and influential people invested a large amount of money in buying ventilators and in providing this type of assistance to the patients. But quite soon after the beginning of the pandemic, we realized that this was just the tip of the iceberg, because human factors, trainers and doctors, and also technologies, aside from the ventilator per se, were needed in order to impact outcome of patients admitted to the intensive care. I work in London at Imperial College, and obviously the peak of the pandemic was recorded where Davide Chiumello, the previous speaker, is based, Milan. But just to give you a scale on how the pandemic evolved in the first wave in London, the first case recorded in Italy was on the 20th of February. In London, Imperial College, the first case we had at Charing Cross Hospital was recorded on the 9th of March, and he was in hospital for 12 days before being identified. So I think the timing of the pandemic was not so different, even if in our country we went in lockdown on the 23rd of March. So looking at this curve, you can see from the 17th of March, which was before lockdown, to middle of May, we had this very sharp peak. This is around 300 cases per day, and the data comes from the Northwest London critical care network. At that time, our manager suggested that one intensivist had to provide care up to 60 patients. Clearly, this doesn't mean that we could see every single patient in a day, but that meant that we had to coordinate the all large staff of people that were not trained at managing patients in the intensive care. So they were not familiar with ventilator, they were not familiar with sedation to keep these patients comfortable and synchronized with the ventilators. Furthermore, at the real beginning, we realized that the pressure and the need for ICU bed was so high all over the world that we were struggling for for drug supplies, as well as equipment, infusion pump, methods to safely deliver such drugs at the bedside. So we had early guidelines, and the basis of these guidelines was the fact that we had to use new methods and combine anesthetic. So we had a more anesthetic operating theater approach instead of intensive care typical approach. We had to use alternative drugs. We had to stop infusion at times and use boluses. And we also had to use alternative routes. That was quite interesting because you might remember that at the beginning, we had to use operating theater ventilators instead of ICU ventilators for our patients. And those were were prepared to deliver inhaling agent for sedation, which could have been combined and were combined in order to spare drugs such as propofol that were more needed, for instance, at the time of intubation. So we came up with a table that suggested the classic anesthetic and sedatives and opioids as first line, but next to those, we propose alternative molecule given in a different way, such as oral diazepam or fentanyl patches, alternative drugs such as the dexmedetomide or even clonidine, which can interact, but I will not go into the details of this interaction because I think the next speaker will talk to you more about these differences, and even drugs such as haloperidol or antihistamines that could sedate the patients in the lack of the common agent. This was quite scary to start, but quite important and taught us a lot of new things. The sedation principle at that time were similar to the period before COVID. And in fact, there was a suggestion of reducing sedations, propose sedation holds and reduce the amount of drugs given up to down 25%. But in reality, at the beginning, we were quite concerned about healthcare professional health. And there was a lot of concern related to the fact that healthcare professionals contracted the infection through droplets and aerosol generating procedures. Anesthesiologists in particular, or the intubation team in different countries, did a lot of maneuver, including the intubation, the proning, the cardiopulmonary resuscitation, that could put them at risk. So there was a high concern about the potential of having a patient that was not fully and deeply paralyzed and sedated. These were some of the recommendations. The American Society of Anesthesiologists, SNAC, they suggested that the personnel should be using video laryngoscopy, as well should be using full paralysis and deep sedation at the time of intubation in order to prevent the spread of the disease. Even high flow oxygen that we regularly use for our pneumonia was discouraged at the beginning of the pandemic. So a very strange setting. This is just a list of a series of international guidelines, which I must confess at the beginning were more focusing on protecting staff at the bedside than considering the best care for the patients going forward. So where are we now? Past the first peak, you can see was quite sharp in the United Kingdom. These are ICNARC data suggesting that we are raising. This is the 1st of November, and now we are mid of November. We're somewhere around here. So what have we learned? We had a nice time in the summer where we could provide some training. We do not have people at the bedside that are completely unfamiliar, let's say, to ICU care. They are much more trained and skilled. And we had also done transfer simulation. We had done simulation with people in the world. So no one is unprepared to, no one is unfamiliar with this type of patients. And we developed a list of technologies that have been quite fundamental to facilitate work at the bedside while limiting the spread of the disease. This includes, as I mentioned, the video laryngoscope that allowed people at aside the anesthesiologist to understand the difficulties of this procedure, as well as protecting the senior anesthetist doing this procedure quite fast and quite safely in terms of aerosol generating related risks. We also noticed over time that patients with COVID, especially those that were prone, have a very significant degrees of swelling. So a video laryngoscope was almost necessary, if not needed, in several times. And what about drugs? How did we manage to spare sedatives in a time of limited resources? For many people that are not familiar with sedation, I always use the similarity of flying an aeroplane. In an ideal world, if you do not have an intensivist or an anesthetist at the bedside, the way you want to fly your plane is using some devices at a control mode. What is our autopilot in the intensive care? What could be our autopilot in the intensive care? Well, by bringing the ventilator machines that we use in the operating theater, we brought some technology that we usually neglect in intensive care. And this includes the entropy or the BIS machine. This is a device that uses a combination of electroencephalography and electromyography to determine a value. The single value can suggest the level of sedation provided by the medication that are given. For 25 years, this technology was available and it's never been systematically used at the bedside. There are lots of reasons for that. One of these is that there are lots of interference, because as you can see, there's a lot of device next to the tools that we use for monitoring sedation, and these cause artifacts which are difficult to interpret, especially with people that do not use the BIS or the entropy on a regular basis. The other problem is that lots of COVID patients had to be prone, and this did not allow to use the device in the front of the head of the patient, which is the natural place to be, but forced us to find alternative positioning. And sometimes when the patients are febrile or sweating or are in a difficult need to be moved for avoiding pressure source, this device in the head are difficult to keep in place. Nevertheless, the B spectrum can guide at the bedside, even those that are not very familiar with sedation, to give the right amount of drugs. This has been mostly studied with propofol infusion. Nevertheless, the combination of propofol with opioids can be well screened at the bedside using any of these devices. What about other medication? Well, midazolam infusion or boluses can also be monitored with a BIS. It takes a little bit longer time. People need to be aware about that. It can be, the value provided can be up to 20% higher when you use midazolam, and can be up to 20% lower when using dexmedetomide. This does not mean that we can't use this autopilot for giving infusion or administering those drugs. Ketamine does not impact very much the BIS, so values can be extremely high, but when combined to propofol, it's much easier to follow the trend. So by experience, we can actually really use this technology, and people that are not trained anesthesiologists can still adjust the infusion or the bolus of these medications at the bedside quite safely. What about new drugs that we use at the bedside? What did we learn? Well, I think clearly, and potentially we will talk more about that with the next speaker, dexmedetomide has been an interesting drug, and certainly it has been used for weaning more than even sedation of these patients. But when we had to introduce this medication in our normal pattern, we learned that we were not familiar, we were not comfortable, we were concerned because, as I mentioned at the beginning, we wanted paralyzed and deep sedated patients that could not spread the disease. Was that the right thing to do? Well, looking back, we have more evidence that actually, for instance, high flow ventilation, non-invasive ventilation, awakening proning, so delaying intubation, is not such a bad thing all the time. We were probably overcautious at the beginning, and we might try to reconsider that point for the second wave. In our team, we got anesthesiologists that did were only part of the intubation team. They were very senior. They had full adequate PPE at all times. None of them contracted the disease during either proning or intubating patients. So with the good training and the appropriate protection, no risks seems to have occurred, at least in our experience. And what about the benefit? For instance, for this drug, some new evidence is coming suggesting that hypoxic patients might benefit. This is a case report. There might be an immunomodulating response that might give some benefit. This is a small single-center study that surely needs to be reconsidered and read with some cautiousness. And we realized from the first speaker that we need to start winning them earlier. So what is the conclusion and the summary of my talk today? But first of all, potentially, if we do not have trained anesthesiologists or we don't have enough trained staff, we can still use technology to help us at the bedside, like pilot use and autopilot. We need to train them and be sure that when artifacts come into the picture, they should not over-sedate the patient because there is no need currently. On the other side, if muscular relaxant are given, the electromyographic component of the train 04 is missed. So the patients, even if he has a very low B score, entropy score, might be awake. So watch out for this. Propofol, when it's used with the Bs, should be monitored, but be careful of using high dose of propofol because propofol syndrome has been reported and is not beneficial to use a single drugs at all times. Deep sedation, very, very much recommended at the first part of this pandemic, might not be necessary. So review the literature, and we are reconsidering the way we manage patients at the beginning. And weaning early is really important because the reintubation rate of this patient in our unit has been much higher than normal. So probably these patients need a tracheostomy, need more time, or need agents that might keep them comfortable, but without the need of taking the tube out too early. I wish then to conclude this and thank you very much. And I hope, as you have seen in this Congress, to potentially invite you in Catania in June next year, where we'll talk about equality and diversity. If I did not answer your questions, please take my contact and either at the end or later on, ask me, and potentially I will be able to answer your questions. Thank you very much.
Welcome to everybody, dear colleagues. Everybody around the world. Is fantastic being able to do this with this newer technology. I have to apologize for the very long biography. Okay. I have to apologize for the long biography. I didn't realize that it was going to be read, but there we go. Now, I have to make a few disclosures. I have various financial relationships with companies, but the most important is that I have been a consultant for Eva Pharma and Orion, and both of these companies manufacture and sell dexmedetomide. So I'm going to talk about sedation protocols, and I have to tell you straight up in the beginning already that it's very difficult to give you a fixed protocol because what you should use depends on the patient in front of you, what drugs are available in your country, and whether there's enough supply, and then how the patient reacts to them. Now, a few years ago, before COVID was around, there were these PADIS guidelines, they're called, published in critical care medicine. And it was a very comprehensive guideline, clinical practice guideline, for prevention and management of pain, agitation, sedation, delirium, immobility, and sleep. So that's where the PADIS comes from. And these guidelines these are the kind of foundation that we use. And there was a strong focus on them for early rehabilitation, for rapid weaning from ventilation, and that this should be achieved by analgesia first, treating and the causes of agitation and distress. The focus is on that, and analgesia has an important role. Then minimization of sedation, prevention of delirium, and improved patient communication. This was before COVID. And now when you have an intensive care with COVID patients, a lot of these principles are very difficult to apply. The patients need ventilating for a long time, and often they need deep sedation. And these are all very challenging. Now, one aspect that I mentioned is delirium prevention, and these are the recommendations of this PADIS guideline. And if you look at all these recommendations, then very little of this is usually possible in intensive care with a lot of COVID-19 patients. The ones I've made gray are the ones that will be are challenging. So what are the challenges in sedation of patients needing mechanical ventilation for COVID? Well, you can divide it into groups of factors, and one is the patient-related factors. And you're all aware of this. Patients need high doses. They seem to become tolerant of their drugs. In some cases, it's thought that they need higher doses because they're sometimes younger patients. There's some evidence that the intensive inflammation, hyperinflammation these patients have also increases the requirements for sedation. They have a high respiratory drive. There's frequent problems with ventilator dysynchrony, and they need prolonged mechanical ventilation, so they need prolonged sedation, and sometimes they also need neuromuscular blockade. And it's a situation where self-extubation is highly undesirable, especially if they're still shedding virus. Self-extubation, accidental extubation is a situation that puts the staff at risk. And then these patients have a high risk of delirium too. So what are the risk factors for delirium? They were summarized nicely by this consensus statement in 2015 in Critical Care Medicine. And there are 9 factors that are associated with an increased chance of delirium, such as a high Apache score and older age, etc. But also mentioned in this analysis was that there's a lower risk when dexmedetomide is used for sedation. And it's very interesting looking at the data that's come out from groups looking after patients with COVID-19. Here are data from the first 64 patients admitted to intensive cares in Strasbourg. And you can see that there was a very high incidence of agitation and delirium, around 65 to 70%. And what's interesting from this data is, of course, despite the guidelines saying that we should avoid benzodiazepines, at this time, probably they were forced by their circumstances to use midazolam in nearly 90% of their patients. And this was even though many of their patients did not have these risk factors for delirium, like they weren't old. I think the average age was 59 or so. And they didn't have pre-existing dementia, they didn't have surgery, and so on and so forth. So delirium seems to be a particular problem. Maybe it's related to there's been quite a bit written about the neurological consequences of COVID, and this probably plays a role as well. Then there's another challenge, staffing. So in my hospital, before COVID, we already had problems with intensive care nurse staffing because they were stressed and many were off sick before it came, and it got a bit worse. And so we had lots of nurses from other parts of the hospital who weren't necessarily accredited or maybe had worked in intensive care before, a long time ago, and were coming back. So, but we had to be flexible with the rules about how many accredited nurses there were per patient, and sometimes there were patients where we certainly couldn't achieve the one-to-one ideal that you would usually have. And this also applied to the physicians. We had non-intensivists working in intensive care, helping out during the peak of the crisis again. So when you need staff that are trained in using sedation scores, in pain scores, to adjust administration, then you need properly trained people, and it's difficult when there's non-accredited staff there. And so I think this also caused a change towards infusions rather than intermittent boluses, because this is easier and for people with less skills. Then there's another challenge that often intensive care in crisis situations is in provisional spaces and with transferred patients. So in my hospital, we were taking patients from different regions of the Netherlands, and believe it or not, the accent, the way that people speak is very different. So sometimes it was even difficult for Dutch patients to understand the Dutch staff because they speak in a different way in different regions. So these are all challenges with sedation, and with also particularly not only with the pharmacological approaches, but with the non-pharmacological approaches. All right, and then there were drug supply problems. So there was a rapidly increased demand, suddenly a lot more patients. At the peak in the Netherlands, we had about 1,400 patients on intensive care with COVID, whereas normally the maximum capacity is just over 1,000. And then we still had non-COVID patients. So there's a rapid increase in the number of patients, and they had high requirements for drugs. In parts of the world, hospitals were stockpiling drugs, and this made then the drugs less available to other hospitals. Then in parts of the world, there were reductions in manufacturing, restrictions on export, and this all led to multiple drug shortages, different drugs in different parts of the world, but a lot of parts of the world, there were drug shortages. So that's the background, maybe, and now we're going to move on to what we recommend. And a lot of what I'm going to say in the next few slides is based on this paper, just recently published. It's available online. It's not in the hard copy, but the first author is Gerald Shark, and it's in intensive care medicine. So it's focused on analgesia and sedation in patients with ARDS, but they've taken into account issues related to COVID, and I think it also applies to COVID patients. So I think patients with severe COVID requiring sedation, a lot of the principles still apply. We should think of the causes of stress and agitation. We should use focused medications. If there's maybe itch, then we should use antihistaminics. If there's pain, we should use opioids and non-opioids. But really, I think still this focus on analgesia should be important. We should use non-pharmacological methods as much as possible within the confines of all the PPE and so on. And where we should try to limit doses of benzodiazepines and opioids. But in many places, people had no option but to use the benzodiazepines. And I'm saying this about the opioids, knowing that I've just recommended that we should focus on pain and give opioids. So it's a bit like this Dr. Doolittle saying that, yeah, that you should give more and less at the same time, which isn't possible. All right. So in reality, around the world, ICUs were forced to use benzodiazepines. And I think an important principle, of course, is that the goals of sedation should depend on the stage of the disease in the individual patient. So where daily interruptions are possible with long-acting agents, then that should be done. And where possible, the goal should always be a light or no sedation. So I've said the sedation management should depend on the phase of the disease. Roughly, you can divide it perhaps into an early phase, the really, really acute, the patient is just in, they've got their respiratory failure. That's generally when they will need deeper sedation. There should be sedation scoring. I've given here RASS scores, and it's often in that phase that neuromuscular blockade is needed. Thereafter, perhaps moderate sedation applied, if not all the time, in bursts when there's ventilator asynchrony or discomfort, despite optimal pain control and optimal settings. And Dr. Q. Miller already told you about optimizing ventilator settings. But where possible, we should go for a lighter sedation. Now, in the weaning and later phases, and with us, it took a very long time, the weaning phase. And I think there we should be aiming for minimal sedation or no sedation, aiming for pain control, ideally using drugs that don't affect the respiratory drive. So these are the recommendations from Schank, which are really very similar to what's in the PADIS guidelines. But in the first line is analgesia, so opioids. And they recommend either fentanyl or hydromorphone or sufentanil. But you have to use whichever agent you've got and whichever agent your people know. I think there should still be a focus on non-opioid analgesics, so paracetamol, perhaps low-dose ketamine if there's a problem with analgesia. If there's tolerance or hyperalgesia, then ketamine can specifically play a role. And another agent that is recommended is nefopam. Now, for sedation and anxiolysis, I think the foundation should still be propofol, but ideally not at high rates to avoid the hyperlipidemia and the propofol infusion syndrome problem. And ideally, less than 20 milliliters per hour or 3 milligrams per kilo per hour. Now, the reality is, from what I've seen, very few patients are adequately sedated on this amount. Patients become tolerant, they need big doses. So inevitably, they're going to need something else. And there's two options recommended by Schank. The one is midazolam, but you should remember that midazolam works on the same receptor. So these drugs will be additive. They're both working on the GABA receptor. It's really more logical, in a way, to add an alpha-2 agonist because it's working on a completely different neurological pathway. Dexmedetomide or clonidine, they work on the locus coeruleus in the brainstem, and it's a completely different system, so it has synergistic effects. And right at the end, after my last slide, I've got some lists of references that show that. Now, this is a rough list of second-line agents that can be considered for opioids. There's morphine, but of course, there are the issues with the active metabolites. Remifentanil, they all have their own problems. Then there's a whole list of second-line possible sedatives, haloperidol. You've heard a bit about the volatile agents, perhaps higher dose ketamine, bearing in mind the psychological, psychiatric problems that can arise, and a few other possibilities there. So is there a role for dexmedetomide or clonidine? I believe there is. In the early phase, with neuromuscular blockade, perhaps not, although if the patient has very high requirements, then possibly one might add dexmedetomide in there because it reduces propofol or other hypnotic agent requirements. In the post-acute phase, when deep sedation is required, dexmedetomide is seldom sufficient on its own, but I think it can best be used as a sedative or analgesic adjunct. Dexmedetomide has a small analgesic effect on its own. It's sedative on its own, but it quite strongly potentiates the sedative drugs, and it also potentiates the analgesic effects. So with this, you maybe can use it to strengthen the effect of your hypnotic or sedative and your analgesic. And then in the post-acute phase, when light sedation is required, it's a possibility as primary sedative and or analgesic adjuvant. And I think it's quite ideal during the weaning phase because it doesn't cause respiratory depression. So patients have anxiolysis, they're calm, just maybe lightly sedated, but have their respiratory drive. Now, there's no free lunch. All drugs have adverse effects. I've mentioned some of the positive benefits of dexmedetomide, but it can also have cardiovascular effects. As I say, all the drugs have their effects. The opioids have various disadvantages. Most of our sedatives cause a decrease in the blood pressure, hypotension, and inhibit respiratory drive. There's only a few that don't. I've mentioned briefly propofol infusion syndrome. For those of you that are interested, there was a recent review in the British Journal on this topic. Now, I think that it's important just to consider drug combinations. They seem inevitable in patients with severe COVID. And I think that smart use of combinations of drugs can have many benefits. Here's some systematic review published just recently about adjuvant analgesic effects. It was a meta-analysis and systematic review. I just need some water. And essentially they're showing that pain scores and significantly reduce opioid consumption. Here's some data here showing you the mean difference in morphine equivalents per day of any adjuvant, but also here's a list of different drugs. And you can see that there's many drugs that will reduce your hypnotic and your opioid requirements. So to start wrapping it up, I think I'm out of time. Sedation of patients with severe COVID-19 is very complex. Polypharmacy is always needed. Essentially, you're coming down to using combinations of drugs of more than one sedative, of an opioid, and not forgetting the non-opioid analgesics. Administration should be guided, as always, by sedation, delirium, and pain scores. And Dr. Rubelotta also told you about EEG measurement, something that I support. Oh. Your policy for your sedation management should be adapted to the phase of the disease, but in the end, it depends on the drug availability, the patient response, and what's there. And there's going to be problems ongoing, I think, everywhere with drug stocks. We have to protect them. We have to think broadly. We can't have fixed protocols, I don't think. We should use adjuncts to reduce the requirements. We should try to combine drugs with different mechanisms of action. And maybe we have to also sometimes rotate through different sedatives. So maybe move from the one to the other, possibly with the opioids. So with that, I thank you for your time and attention.
I think I understood the question, and I think that is very relevant. Louise Blanche before said that technology has never been so important and so advanced as during the COVID period. And this bomba intelligentsia definitely will be very useful, given that, as we said several times, we have no trained people all the time at the bedside. So the risk of making a mistake in this scenario is very high. So whatever can be simplified, whatever can be guiding the work is fundamental to improve outcome. So yes, I don't know how much can be used across the globe because it's quite expensive and difficult to implement. But from a theoretical point of view, it is really important to consider that during the second wave, I think.
Thank you, Francesca. For Tony Absalom, a question with regards to the use of dexmedetomide would be interesting to use it during the night and with free periods during the day, and how much time can we use it, because the mechanical ventilation days are very prolonged. Is it adequate to do it more than 14 days?
So that's a very interesting question. Yeah, the specific thing about dexmedetomide is that it seems to have effects on the natural sleep pathways. And Mervyn Maze's group, when he was working in Imperial in London, showed this very nicely with rat studies, the effects. So dexmedetomide can have effects very similar to natural sleep. So the idea of using it over at night, I find is very logical and a very good idea. Now, a lot depends on the licensing. So in how long you can do this for. But I think that in the States, in the United States, it's only licensed for 2 days. But the European license, I don't believe, has a restriction on how long it can be used, and continuously. And dexmedetomide is not as fast acting as propofol. It accumulates a little bit. So probably just giving it at night and then stopping over day would help it to clear. It doesn't stay around that long, but it would actually be quite a logical way of doing it. Might help the patients get a more physiological type of sleep.
Thank you very much. I think Dr. Kimelo is not here. We don't have any more time. Thank you for your participation, and thanks everyone who's listening to the presentations. Good afternoon. Thank you.